Welcome, everybody. Let's have some fun with upper GI cancer. So you're all here for cases from the community for us to discuss available research to help guide the care of gastroesophageal cancer patients. I'm Sam Klempner. I'm joined by Dr. Zev Wainberg, Dr. Florian Lordick, and Dr. Yelena Janjigian. We're going to go by first names because we're all friends, and we'll see if we're all still friends after this is over. But all right, I'm going to cruise through the disclosures. Here are the faculty. Everyone's disclosures, you have all these slides, so these are publicly available, and I'm just going to move through so we can spend our time on what you're all here to talk about. And now, without any further ado, we're going to dig into gastroesophageal cancers, which are the most important tumor type, of course. So here's the agenda. It's basically a format of breakdown into modules, which should cover the big topics. There's going to be a couple cases where we'll address questions from oncologists who are taking care of these people. And then we'll have a little bit of presentation where we'll provide some data that will serve as sort of the framework to just discuss the topic. It's not meant to be an in-depth didactic. It's meant to be more interactive. And then if there's time, we'll get to more questions. So here are the modules. Here are the oncologists who will be providing cases, and thanks to all of them for taking the time to develop some cases and record the videos, which I think adds a real human kind of perspective rather than me reading something that says a 67-year-old person with XYZ. A couple more of the oncologists who are involved. All right, I moved through that quickly to try to preserve some time for the modules. Let's get into a very hot topic, which is optimizing the selection of therapy for newly diagnosed patients. And this is my section. So we'll lead it off with a case.
Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library. Tonight, our panel of oncologists will present cases of gastroesophageal cancer from their practices and questions they have about management of these patients. Beginning with Dr. Victoria Giffi, who has a 55-year-old man who presented with a partially obstructing adenocarcinoma in the mid-distal esophagus with retroperitoneal adenopathy. The PD-1 level was 100%.
This gentleman, extremely healthy at diagnosis, in his mid-50s, EGD showing a circumferential tumor in the mid to distal esophagus and also extending into the cardia of the stomach. His PET-CT unfortunately showed stage 4 disease with adenopathy in the abdomen. We confirmed metastatic disease by biopsying a left para-aortic lymph node just to make sure. I started oxaliplatin, 5-FU, and leucovorin while waiting for the PD-L1. His insurance didn't want to get it at first. We eventually got it, and it was actually 100% by immunohistochemistry. So we added nivolumab to cycle 3. He just had his interim PET-CT performed this morning. He remains in what looks like a complete response.
That's really interesting. What are the questions you have?
My question about this gentleman is, if he remains in a complete response on maintenance, would you consider sending him for definitive surgery, especially if we continue to have trouble with this stenosed esophagus? Would it help for him to get surgery? Is there a role for radiation at all? If we just send him for surgery and then continue 5-FU nivolumab maintenance, would that be enough?
Did you say that the insurance company wanted to see the PD-1 level?
They did. And not only that, they wanted a CPS score. I see that a lot, actually, Neil. It's really frustrating.
All right, well, very, very real-world case that actually is similar to a question that Yelena got during the oral abstract session earlier today. So maybe I'll start off with you, Yelena, in terms of you have a very large experience with FOLFOX and PD-1, and you've certainly seen patients who have a CR. Do you think about consolidation to the primary with radiation, as was mentioned, or surgery? Or how do you think through these patients who do really well?
Yeah, that's a great question, and congratulations on this great result. I think the time is an important part of this decision formula. Time on therapy, understanding the disease biology is critical. We don't immediately understand whether or not surgery will help some of these patients. It sounds like this is relatively early on in the disease course. Typically what we do is at 4 months, if there's radiographic evidence of what appears to be a complete response, we do an endoscopy. And often if there's systemic disease control, the primary tumor is also under complete response. If, like in this patient, the concern is for clinical progression and the primary tumor is not in as good of control, then we present the case at the disease management team. And then either radiation or local form of definitive therapy, such as surgery, could be considered. In a patient who is relatively young and otherwise fit, my preference would be go big or go home, do surgery, and radiation doesn't cure these people. RP lymph node only disease, typically they do better. We have data coming out of Europe with FLOT regimens that RP lymph node metastatic disease could be approached with definitive surgery. In 6 months to plus, if there is no metastatic disease and the primary tumor was still in place and you're concerned that it will misbehave in the future, surgery could be an option.
All right, I'm going to go right down the line really quickly. What PD-L1 assay does your institution use? And start with you, Yelena, Florian, and Zev, and then me.
We use the E1L3, whatever, the cell signaling one. The rate of PD-L1 CPS 5 or greater is way under called with it. So we actually now, with the zolbetuximab data coming out, we're trying to understand what other assay to use. It's if your hospital does not have, the capabilities to do 28/8, it's a relatively outdated technology. They're not going to invest in it, and so that's the problem.
Florian, what about your institution?
Mostly the 22C3, but the other platforms and antibodies are also available. And it's obligatory in Europe. If you want to use IO, you have to get the CPS.
Yeah, that's definitely going to be a theme that we're going to come back to.
Yeah.
And Zev, what about UCLA? What do you guys use?
Same, mostly 22C3 with some 28A interposed periodically.
Yeah, we also use the E1L3N clone from cell signaling. So it just gets at the issue of heterogeneity in the testing and potentially even different rates of positivity. Let's get back to the final question, and maybe Zev, I'll throw this to you. How are you factoring in PD-L1 status? Are you getting it for everybody?
Yeah, I mean, I think everybody ought to get PD-L1 tested in this cancer. I mean, in the metastatic disease like this patient, it's certainly clear that PD-L1 testing should inform treatment decision. It certainly informs, as you'll hear in Europe, but even in our country, it should inform, in my opinion, treatment decisions. So I test every patient for PD-L1 by CPS score, regardless of vocation and regardless of histology. Whether we act on it to the same degree in every patient is variable and really depends on clinical context and each different scenario, though.
Yeah, I think our general framework is kind of similar. I think it's about time to move on to the next case. So we got a couple more cases coming.
The next two cases are first from Dr. Matthew Strickland, who has an 80-year-old woman with a history of stage 0 CLL, now with locally advanced unresectable gastric adenocarcinoma, and another case, this from Dr. Priya Rudolph, who's been providing care to a 61-year-old man with localized adenocarcinoma of the GE junction, who's received the cross regimen, but was found at surgery to have metastatic disease.
She went on to receive 2 cycles of dose-reduced FOLFOX and nivolumab. She presents for cycle 3 with shortness of breath, a hemoglobin of 6, elevated LDH, undetectable haptoglobin. Coombs test is positive with both IgG and complement. She receives prednisone and rituximab for impression immune-related warm autoimmune hemolytic anemia. Hemoglobin remains stable over the next 6 weeks. For this patient, would you re-challenge with nivolumab?
61-year-old gentleman who happens to be the father of someone that's starting Hem-Onc fellowship. He started on concurrent chemoradiation therapy, standard weekly carboplatin Taxol, went in for esophagectomy, which unfortunately showed metastases. Based upon that, he did not undergo esophagectomy. The only mutation he had was ARID, ARID1A mutation. I started him on modified FOLFOX6 regimen along with nivolumab. Sadly, he had ongoing worsening dysphagia, severe pain. I would love to know if the faculty have encountered any similar cases where they have proceeded with esophagectomy despite a metastatic disease just for quality of life and debulking. I would also like to know if there are any clinical trials with this mutation.
All right, two really straightforward ones. So the first one is really centers around immune-related adverse events, in this case, a warm hemolytic anemia. So maybe I'll start with you, Zev. How do you manage IRAEs in general? Do you have sort of a specialized team? How are you thinking through this, and do you have any experience with this particular IRAE?
So, I mean, I think all centers have people we go to for IRAEs dependent on what organ is affected. And I think that there are certain organs where IRAE is a hard stop. We'll never re-challenge that patient with immunotherapy, particularly if they have severe pneumonitis or autoimmune hepatitis. I mean, those are, if it's severe enough, I think hard stops, not worth the re-challenge. I have not personally encountered warm, what did we call it? Warm autoimmune hemolytic anemia. And it's been a long time since I've done a lot of hematology, to be candid here, but I'm going to go out on a limb and say that this is probably something that I would consider re-challenging as long as the patient was down to a low dose of steroids, so you're not going to decrease the efficacy of presumed PD-1 inhibitors. So I think this would fall into the latter category where I would consider it, but I'd probably ask a board-certified hematologist to help me out on this one. I let my boards lapse quite some time ago, for the record.
I'm in the process of letting them lapse right now. All right. Florian, the second case was also complicated, so two-part question. One is ARID1A and potential functional implications, if any. I know there's been some association with higher mutation burden, given that it's part of the SWI/SNF chromatin binding complex. And then more broadly, sort of an overview of where you think NGS adds identification of actionable findings.
Well, actually, real NGS in our institution, we are using it not so much upfront. I don't have a specific answer for this mutation, but we will certainly discuss that in our molecular tumor board and explore the databases and see if there is any indication for more experimental treatment. Difficult to say what we would do, what the colleague also asked regarding the control of the local disease. Going for an esophagectomy in a metastatic patient is certainly not our standard and is restricted to very, very specific cases, never pushed by our tumor boards. We have some patients who want to go for that, where we discuss the risks, where there is a low metastatic burden, but it's not our routine to go for that.
Yeah, I agree. I think, it's not a simple palliative surgery to do an esophagectomy for sure. What about you, Yelena? You mentioned sort of management of the primary and someone who has a refractory primary. Would you think about something locally ablative for this patient?
I certainly would consider it. I think a stent may be a good option, or a feeding tube. I'm worried that a lot of his symptoms are actually from peritoneal disease, and I would echo Florian's point. I would not. I recommend surgery, as heartbreaking as it is for the family and the clinician. Surgery is not going to help this patient. He may not be able to, survive it because these patients are nutritionally compromised. But radiation, a short course of radiation with maybe a fluoropyrimidine as a radiosensitizer or a stent would be our way to go.
Yeah, I think similar, definitely use palliative RT with 5FU. Tend to avoid stents when possible, but definitely always an option. All right. So those two cases sort of set us up for a little bit of discussion around standard approaches to frontline, which is the topic that I'll be walking us through. So we're going to mainly focus on the HER2 negative microsatellite stable metastatic patients, and then talk a little bit about MSI in non-metastatic patients. Was a hot topic at some of the abstracts today. So just as a reminder, this is a really heterogeneous population, and I think as timeline goes, we're plucking off little branches on this tree. So you've got a whole bunch of people with different biomarkers, and MSI, I think the management is really kind of coalescing around IO. HER2, we have some of the people who've developed some of the HER2, but that is sort of a more standardized algorithm. And then we've got the rest of the patients. And maybe Claudin will be a new branch off of this, but most of these patients are still lumped together and managed with chemo plus or minus IO approaches, but we don't know, and we may never know, how some of these small molecular subgroups do within a given therapy. I think most of the audience knows this, but the biomarkers that you need to know for all advanced are certainly HER2 and MSI status, or MMR. I think all of us would argue that PD-L1 is a biomarker that really needs to be known for all metastatic patients who are candidates for therapy. I make the figure here just to note that most of these are IHC-based tests, and NGS can provide a lot of complementary information, particularly around MSI status and some of these other markers, FGFR2, et cetera. We've learned a lot about MSI high disease, and so the TCGA is largely a non-metastatic cohort, and they identified a prevalence of about 22%. In the non-metastatic clinical trials, it hasn't quite borne out that high, probably more in the 7 to 10% range, and I'm just providing some references here from the large retrospective and the Dante trial. And then similar to colon in the metastatic setting, MSI is even less prevalent, probably in the 3 to 5% range at the most. So this is a rare subgroup, but a well-defined subgroup. And we know that checkpoint inhibitors work in these advanced patients. Response rates probably in the high 50s. Doesn't seem to be dramatically improved upon with chemotherapy from the trials that have direct comparisons. Ipi-Nivo may improve the response rate a little bit, as was shown in 649. But these are patients who do well, largely. The 24-month median overall survival rate is in the 70% range, which is dramatically improved upon compared to chemo-IO. And then if these people respond, it's usually very durable. So why do you need to look in the non-metastatic patients? Well, one, it's a prognostic feature. These people do better. They have an improved 5-year disease-free and overall survival. This is from a retrospective JCO paper. And perhaps even more clinically relevant is that they don't appear to benefit from our current perioperative or adjuvant chemotherapy strategies. Granted, this retrospective did not include FLOT, which is the modern standard, but I think this has held up across other tumor types with similar kind of approaches. So it begs the question of what about moving ICIs into the neoadjuvant space? And certainly there's good rationale to do this while the primary tumor is intact. You get a more diverse T-cell response in terms of TCR repertoire and diversity, and you also get a better quality of T-cells when the tumor is intact. Of course, there has been adjuvant IO strategies like 577. So this is just one recent trial. This is now published, the Neo-Napiga trial. These are patients who got Ipi-Nivo up front, then got surgery, and then got adjuvant Nivo. So basically a 1-year paradigm of perioperative IO. And what you see is that the path CR rate is very high, almost 60%. And then even more important, and this data is partly from Memorial in esophageal, that the major pathologic response is almost 80%. These are people who have near path CRs. And the EFS and the OS curves are things that we would love to see for any trial. It's basically a flat line with one person censored, but I will caveat this is short follow-up. So basically, I think that we're moving towards managing non-metastatic MMR or MSI high patients differently. We approach it with, again, testing everyone as the first step. We have a discussion. We think about surgery up front. We're not considering chemo-alone approaches. If neoadjuvant IO is an option on protocol, and I've done this off protocol a few times too. That's our preferred approach. And in the metastatic setting, you can make a debate about who needs chemo and who can get away with IO alone, and we can certainly maybe get into that. I'm just providing this for background. I'm not going to go into the PD-L1 prevalence studies. So chemo-IO is here. Everybody knows that. This is clearly showing that we have a separation of the curves, and it stays separated, and we just saw the 3-year follow-up update, which I'm inferring from this Nature paper because I didn't have the curves in time. But we also know that there is an increase in toxicity when you add a new drug, no surprise. And so it has led to a lot of analyses about how do we pick who are the best people. And I'm just highlighting some very clear trends here. So top is Orient 16. And you see the hazard ratio is improving as you move the PD-L1 strata up. If you look at the bottom, that's Checkmate 649. You see the same thing. Hazard ratio goes like 0.7, 0.6, 0.6 lower as you move up the PD-L1 strata. So it just means that we have to have these discussions around patients. to me, and I think to all of us, it means that you also need to test to know this because it will help inform your discussion. I'm a simple person and I like pictures, and so this is another way of showing the same thing. I think you take two tumors, maybe one's PD-L1 CPS 10 and the bottom one is PD-L1 CPS 0. You give them the same treatment and you see a differential magnitude of response. One patient has a great response, in this case the larger plant, and one person has a limited benefit. And so the question is, how much are we helping the people in the bottom? And you can see the hazard ratios there for context, which suggests that we may not be helping some of those really low, particularly the CPS less than 1 patients. Several of the authors are up here from this recent ASCO guidance, which is a really great document, and I would recommend anyone interested to read this. But essentially, ASCO has taken the approach of using PD-L1, which is different than the FDA label. Technically, we don't need to test to get access to nivolumab in the front line in the US. I think these thought leaders agreed upon this framework to suggest that the very low or negative patients are not getting benefit and recommend FOLFOX alone. The 1 to 4 group is a group where it's a case-by-case discussion, and certainly you want to assess the quality of the PD-L1 testing. And the greater than 5 group, there's a clear consensus that these are people who are driving the benefit. Junction is similar, but when you get into esophageal, it gets a little bit more complicated because there's data around the 10 cutoff that we may hear about later. But this becomes and underscores the need for shared decision-making to think through the sort of mid-range patients and how much benefit are we providing for them. So this is sort of the debate that has happened. This is nobody up here in particular. This is just a cartoon I found. Some people use biomarkers, but technically you don't have to. I think one of the themes that will come from this is that a lot of people believe in the biomarkers, and we'll hear about that in a minute. I don't actually know why I kept this slide in. It's basically another way of showing the same thing. But certainly the tumor, an MSI high tumor, it doesn't have a lot of moves to make. If you give checkpoint inhibitor, most of those patients will benefit. And the tumor doesn't have a lot of intrinsic resistance, whereas some of these PD-L1 low tumors, they have moves that they can make to get out of that situation. So I think just another picture that I liked. There's a lot of other trials that have supported this paradigm. I mentioned Orient 16. We saw Rationale 305 today, which I didn't have time to include. And now we have Keynote 859, which is a positive study on press release, but we haven't seen the data. Another large trial supporting this idea. Take-home points are in the slides. I'm not going to go through them because I'm like a few seconds over. And now we'll move on to Module 2 with a couple cases.
The next 3 cases are of HER2-positive gastroesophageal cancer. The first is a 31-year-old woman being cared for by Dr. Farshid Dayyani, who was considered unresectable because of retroperitoneal adenopathy, but is now having an excellent response to FLOT, nivolumab, and trastuzumab.
This is a doctor, actually, a resident, who comes to clinic with weight loss, epigastric pain, ultimately gets EGD endoscopy, and biopsy shows poorly differentiated adenocarcinoma, as you would expect, signet cell features. She's M1, and on PET scan, she has retroperitoneal adenopathy. Patient also has a FGFR2 amplification, P53 mutation. The patient comes in, she's a resident physician. She says, how's my HER2? I'm like, probably negative, let me check. And I open the path, and lo and behold, it's actually 3+ IHC. She also asked if her tumor is Claudin 18.2 positive. We treated her with FLOT Nivo, and then I added trastuzumab to that. She had a great response, obviously gaining weight, tumor gets better, she's eating better, energy is better. The nodes are much, much smaller, marked decrease in size of the tumor. So the question is, what would the panel do? Would they attempt surgery? What's the role of palliative gastrectomy in this setting? The surgeon was very, very adamant that it improves her survival.
All right, a lot to unpack in that case. I'm going to start with you, Florian. So maybe just give us a reminder of the standard, calling for HER2, what is positive, what is negative. what is your institutional practice for the first line? And you have a lot of experience with FLOT, so have you ever sort of done this FLOT, TRAS, NIVO?
Yeah, it's interesting because actually I have a very similar case that went to complete remission, which remained on that complete remission for a year, and now this patient was progressive, and we switched to trastuzumab deruxtecan. We are using the traditional criteria for HER2 positivity. We are going for immunohistochemistry, and only in the intermediate cases we are adding the in situ hybridization. And the standard in Europe is a bit different from the US because we are currently not allowed to combine immunotherapy with trastuzumab, but some patients get it, and it's probably the best treatment for such a patient. The complicated question again is what to do with the stomach. I do not believe that a palliative gastrectomy is the way to go. There are negative studies. On the other hand, if there is a chance to resect everything, including the lymph nodes, the regional lymph nodes, maybe single metastasis, I would consider it for such a patient if it's really oligometastatic disease.
Yeah, Yelena, I'm going to build on that question for you, which is, as someone who has a lot of experience with this, do you think about the PD-L1 at all when you're deciding in the frontline management of HER2 positive patients?
Typically not. Most of them are PD-L1, at least CPS1 or greater. So, but HER2 is what drives the boat here. I mean, a patient like that, I think a laparoscopy would be important to understand what we're dealing with. And another, signet ring cell, it's funny, he said probably not HER2 positive, but signet ring cell tumors typically are not. My strongest HER2 positive case for expression I've ever seen was a signet ring cell young patient, but she had a germline CDH1 mutation. So a very interesting case. So I would absolutely, in this young woman, screen her for CDH1, particularly since we do see sometimes de novo germline alterations.
Yeah, I think the more we test patients, the more we find these, undiscovered germline, sometimes pathogenic, sometimes we wind up reclassifying. So, Zev, how comfortable are you? I think we all have a lot of experience with FOLFOX and TRAS and NIVO together now. Let's say a person couldn't get oxaliplatin. How comfortable are you moving around the chemo backbone if you needed to?
I mean, I think platinum 5FU, FOLFOX, 5FU cis, if you need to play around with those things, CAPE cis, I think most of the data is interchangeable as far as I'm concerned. If you look across studies in aggregate, most people would handle, I think, oxaliplatin-based therapy a little better, particularly if you limit dosage and not let the neuropathy linger too much. But I feel pretty comfortable interchanging platinums and 5FUs at this point.
And Florian, I know you have some experience with HER2 in the neoadjuvant space. So despite the data that's out there, do you think that we still need to investigate HER2 as a neoadjuvant paradigm? Would you consider it in a borderline resectable patient where a maximal response might get you to surgery?
In a borderline, yes. I mean, we would treat a borderline resectable patient like we treat a metastatic patient, so I would see a clear indication for adding a HER2 targeting compound just to increase the response rate. That's certainly good to do that. In the clearly resectable ones, we have some indicators from PITARCA trial and some others that we may achieve more complete remissions, but it's not yet established. So we need more studies in that field, clearly.
And Yelena, you have access to PD-L1 in combination with TRAS, so same case. If you could give Keynote 811 regimen to someone who you might ultimately want to take to surgery, or even do you think we need to investigate that combination in non-metastatic patients?
Well, again, I would say if it's locally advanced borderline resectable, it's a good plan to combine immunotherapy, HER2 therapy, and chemotherapy, not in the clearly resected cases, resectable cases. I think we need studies for that.
Yelena, same question.
FLOT is a bit overkill. I think it's, my experience even combining FLOT with anti-PD-1 therapy, you do get higher grade 3-4 toxicities. And so to put FLOT plus NIVO plus trastuzumab, it was a bit, for a woman who has stage 4 disease, and you're sort of burning through all your options up front, was probably not what I would do, but it's certainly, I understand the sentiment behind it. I think for early stage disease, a clinical trial is critical. We have investigator-initiated study activated for those patients. So I don't think you need a third drug cytotoxic. It's too much.
Yeah, I mean, I agree with that, and I'll say that, because hard to imagine we're going to have a higher response rate in this disease than what we saw in Keynote-811. So when we've achieved a certain response rate, it's hard to imagine that additional taxane here in this context is going to necessarily give you that much more. If that's what you're aiming for, which is response. If the argument is, there's a chance to cure this patient and you want to give perioperative taxane, then it's kind of a different context. And I think this patient falls somewhere in between. And we all have had patients like this where we're hoping that, they're going to be on that curative spectrum. So that, I think, plays into that decision.
Yeah.
And then really, really quick down the line, your preferred choice for a stage 4 HER2 positive patient, what's your first line? And we'll go Yelena, Florian, Zev, me.
I'd like to start with Zev. You know what my answer is?
Yes.
I mean,
know what you're
we just said it. First line HER2 positive, I think they should get, personally, FOLFOX, trastuzumab, pembrolizumab. I think that, it's a FDA accelerated approved. We'll wait for Yelena to present the progression-free
Not
survival.
K-Pox? You would do
overall
FOLFOX?
Yeah, I'm a bit of a FOLFOX person, as it turns out. But especially because I worry about the higher dose of oxaliplatin in a lot of these patients. But yeah.
So we do FOLFOX, Traz, Pembro as well for the most patients for similar reasons. In addition, I think in the Northeast, a lot of our patients present with more proximal tumors and GE junction, and capecitabine may not be a realistic option for a lot of our population. And then in 30 seconds, Florian, EU perspective on first-line HER2 positive.
Well, we do not have access to Pembro in Europe, so it's FOLFOX and trastuzumab as our standard. And of course, K-Pox is also an option, but I personally like FOLFOX better. It's a bit better tolerated, in my view.
Awesome. All right, let's get on to the next couple cases, some more good discussion.
The next two HER2 cases are first from Dr. Warren Brenner, who's treating an 86-year-old man with newly diagnosed HER2-positive gastroesophageal cancer metastatic to the liver and lung. The tumor is 3+ by IHC for HER2, and the PD-1 level is 10. The second case is from Dr. Matthew Strickland, a 75-year-old woman with HER2-positive esophageal cancer and brain metastases, whose status post-stereotactic radiosurgery and is receiving first-line 5-FU platinum chemotherapy, trastuzumab, and pembrolizumab.
This is an 86-year-old male who presented with a dysphagia and was found to have a gastroesophageal cancer. He unfortunately had metastatic disease to the liver as well as to the lung. He was HER2 positive by IHC 3+, and also had PD-L1 positive 10. He had good functional status and wished to be aggressive despite his age of 86. So we elected to treat him with FOLFOX with slightly modified doses, together pembrolizumab and trastuzumab. My question for the investigators is there a role for trastuzumab and pembrolizumab without chemotherapy in the elderly patient with metastatic HER2-positive GE junction cancer? If this patient progresses on his current therapy, would the investigators use trastuzumab deruxtecan versus a taxane-based therapy? And do they have any pearls in the management of trastuzumab deruxtecan toxicity, particularly the pneumonitis?
75-year-old female with advanced HER2 positive esophageal cancer and brain metastases, status post-stereotactic radiosurgery to CNS disease, who is receiving first-line 5-FU platinum chemotherapy, trastuzumab, and pembrolizumab. Should an MRI brain or CNS imaging be part of standard baseline imaging and workup for patients with gastroesophageal cancer? And does HER2 positive status change your approach to this question? At the time of progression of disease through first-line treatment, what would you recommend for this patient in the second line?
All right, so we're only going to be able to get to a couple points from these cases, and I'm also judging everyone's Zoom background in my head when I'm watching these being presented. So I'll start with you, Yelena. So you actually have some data around the first question, which is chemo-free approach with Traz PD-1. in
Yes.
HER2 positive?
So our initial phase 2 that resulted in Keynote 811, we actually started without chemotherapy and did one cycle of Pembro-Chaz as a way to understand disease biology and see results. And more than 50% of patients who received what we called induction did have tumor shrinkage. It was not as homogeneous or sort of uniform as you would expect with combination with chemotherapy, but there were some patients who even made PR criteria just after one dose of Pembro-Chaz. I think in the patient, as was presented, this octogenarian, my preference would be at least to try with some dose-reduced chemo, maybe low-dose 5-FU or oxaliplatin. I think even in elderly, if their functional status is adequate, so I basically dropped the boluses, decreased the 5-FU, to 1,000 milligrams, and oxali is at 60 milligrams, and they usually do okay. I mean, I agree with earlier comments that FOLFOX typically is better tolerated. It's tricky because I actually don't love Pembro every 6 weeks. So in those cases, I actually use Nivo Traz, and I've not had any issues with that.
I mean, when I come to you guys and I'm 88 and I have HER2 positive disease, you have permission to give me FOLFOX, so just so you know.
Well, by then I'll have much better options.
Yeah.
Or I'll retire. So.
Dev, real quickly, so we've seen that maybe HER2 positive patients have a higher incidence of brain mets, or maybe more brain mets turn out to be HER2 positive, but do you think we need to start looking at this ahead of time? Like, if you're putting someone, you have a lot of experience with early phase trials, I mean, are you feeling the need to screen the brain?
I don't think we should be changing our staging guidelines for it based on a pretty low incidence. It's still not that common. And I'm not dismissing that it's more frequent in esophageal cancer, more frequent in HER2 positive. I think we're getting better at managing brain metastases, particularly if if we find it. But I don't know if I would routinely change my staging in all patients to include brain imaging outside of any symptoms. I think that's I don't know what the others have to say, but I wouldn't automatically do that.
Yeah, agree. I think
I will say that we're picking up tiny lesions more and more, right? If you really look carefully, in a lot of patients, and the MRI technology has gotten so much better, and the ability to find a sub-centimeter lesion is so much better. We are picking up more, but it's still not common enough.
Yeah. All right, I'm going to cede control to Yelena for the HER2 module.
Great. Well, thanks. And so we'll talk about HER2. Depending on where in the esophagus and the G-junction and gastric tumors you look, the rate of HER2 can be variable. The higher up in the track, it could be as high as 30% HER2 positivity defined by IHC, and certainly for IHC 2+, FISH-positive patients. We know that trastuzumab chemotherapy improves survival. This was based on the TOGO regimen that was published over a decade ago with overall response rate of 47%. We also know that not all HER2 tumors are created equal. You hear this all the time. Well, in gastric cancer, it's not as important as in breast cancer. I would disagree. I think it's more important. But also, you need to understand the complexity of it. Most of our HER2 tumors have higher level of aneuploidy in GI tumors than in breast, and therefore, they're more complicated. They have more alterations that are MAP kinase driven and may lead to escape pathways. So we just got to be more creative about targeting it. But there were a lot of negative studies before the recent positive studies. We had Logic, Jacob, Eloise, and so forth and so on. The recent approval of pembrolizumab, trastuzumab chemotherapy, I think really sort of made way for the idea of tumor targeting together with anti-PD-1 therapy, at least to help shrink the cancer. Whether or not it's going to translate to meaningful overall survival benefit, it's to be determined, but we're hopeful. And what's great about the recent advances is that we were able to really demonstrate that targeting HER2 beyond first-line therapy is a validated approach with the trastuzumab deruxtecan data. And so now there's a real, a resurgence of this approach in second line and beyond. So why do these tumors in first-line setting don't do well, with other HER2-directed therapies like doing, small molecules inhibitors and so forth. Well, as you see here, and this was published a while back, because of RTK alterations and because of variable level of HER2 between the primary and the tumor, or even just within the primary, targeting HER2 with just more HER2 is not a good idea. You need to target, in addition with HER2, with other inhibitors potentially. And these are stratified hazard ratios in a retrospective data analysis of first-line trastuzumab-based therapies with chemotherapy. And you see here, if you have a RAS-altered tumor with relatively low quartile of HER2 amplification, you will do poorly. So we, as I mentioned, showed this data in the phase 2 setting. This was published in Lancet Onc that showed that 91% overall response rate if you target HER2 with PD-1, because PD-L1 overexpression is actually a mechanism of resistance with HER2-directed therapies. This was really nice. We were able to demonstrate that ctDNA was a helpful way to predict who will do the best. If you have a high level of HER2 to the point where you have it in this blood, in the plasma, you'll do better. And the biomarker analysis actually showed that, you can't really see it on the slide, but PD-L1 was not a predictor. In fact, PD-L1 negative patients or lower expression patients may have done better with pembrolizumab. And again, part of it is because probably it goes back to the trastuzumab as the main thing that drives the responses, and then anti-PD-1 therapy just helps it. And as you know, these tumors are SIN, so they're not MSI. That was a very common question people used to ask me, what percent of our MSI? Well, 0, because HER2 and MSI is pretty much mutually exclusive. So I think I put this case in. It's very similar to what was discussed before. It was one of those locally advanced, kind of borderline resectable tumors with diaphragmatic invasion, with really bulky disease, HER2 high, RAS and MYC wild type, which is, you knew that patient was going to do well, with positive ctDNA for HER2. So when those patients come into my clinic, it just makes my day, because I know they're going to do better, right? They are going to have these outlier responses, and I love it. So after 4 cycles, the guy, an amazing response, and then kept going. But despite all of that, he had persistent disease on endoscopy, even though the PET showed SUV of 2.9, right? So scope those patients. They will be certainly interested in knowing what the status of their disease is. And then he went on to have surgery, YPT2 and 0 tumor. And to the point that Sam made earlier, you should resect any disease that was there before. So if the patient had RP lymph nodes, we usually have our germ cell GU people go in and do the RP lymph node dissection just to take it all out. Keynote 811 demonstrated high response rate with this regimen in a phase 3 setting. We saw nice responses. And what's nice is that Panthera study was a follow-up phase 2 study after we did published ours that was actually conducted in Korea almost in parallel, that showed also high responses with this regimen. And we saw a delta of 23% overall response difference, which was not seen before in the phase 3 setting. And what's nice, it's a placebo-controlled study, so immune-related adverse events or any adverse events were essentially equivalent. So the regimen was very well tolerated, and in some ways that's why some of the other trials have stalled, because everyone's hesitant to go against pembrolizumab because it's so well tolerated. We know that acquired resistance is an issue with us. You lose HER2, you gain other alterations. Basically, everything you saw as a de novo resistance at baseline just happens more often the longer you're on therapy. So I think the best thing to go after is earlier, untreated, first-line patients, or even potentially locally advanced non-metastatic patients. By the time you wait to second or third-line therapy, it's a noisy tumor, it's not as HER2-driven, and it's harder to target. But despite all of that, Destiny Gastric 01 and 02 demonstrated benefit for ADC, antibody-drug conjugate, T-DXd, which has a very high drug-to-antibody ratio compared to T-DM1, that was not a successful strategy. And the overall response response rate in second line or third line, so third line was the Asian study, second line was the European single arm study, are very similar. So even though a second line study in selected patients, the responses were not higher. And why is that? I think because you're either HER2 driven or you're not. And in non-Asian, in the European cohort, there were higher rate of GE junction tumors, so more chromosomal instability and more aneuploidy. Toxicity, interstitial lung disease was mentioned, certainly is a scary thing for an oncologist and a patient to experience. So read the fine print on your reports, look at the scan. If you have any ground glass opacifications, so even grade 1 pneumonitis, I would hold the treatment and monitor the patients. Most of the patients, at least in experienced hands, do well with either monitoring or steroids for grade 2 ILD. But certainly, deaths have been reported. Basically, the data suggests that biopsying on second-line therapy is important to understand the rate of HER2 positivity. We have Destiny Gastric 03, with looking at first-line TDXD in combination with pembro and capecitabine. What we know is that there's high rate of discordance for central versus local HER2. 20%, in my opinion, is high. So these studies need to continue to maintain central confirmation of HER2. PD-L1, though, is also very high, same as we did in KEYNOTE-811. Destiny Gastric 03 tested for PD-L1 positivity. 85% of patients HER2 positive are PD-L1 positive as well. Thank you for your attention. So pembro-chaz FDA approved in first-line setting. TDXD is now approved in US and almost Europe, right, in trastuzumab refractory settings, right? So if you biopsy a patient if they're HER2 positive, you can do it instead of Taxol/Ram. The responses are better. I think the tox is managed if you know what you're doing, dose reduce, et cetera. Thank you for your attention.
Awesome. Awesome high-level overview for HER2 positive disease. So that brings us to module 3, with Florian is going to walk us through, which is very important and perhaps somewhere where we really need a lot of work, which is patients after frontline, later line therapy. So we'll open up with some cases, and then Florian will bring us home at the end of the module.
The next two cases are first from Dr. Namrata I Peswani, who provides care to a 76-year-old woman with Lynch syndrome and a past history of stage 3 colon cancer. The patient presented with gastric carcinoma with liver and lung mets.
She was the first person in her family to go through genetic testing, even though there had been multiple family members with cancer before her, and she was confirmed to have Lynch syndrome. There's always this question about best first-line management versus just a PD-L1 positivity.
The second case is a patient of Dr. Ranju Gupta, who's treating a 61-year-old man with 70-pound weight loss and locally advanced high-grade neuroendocrine carcinoma of the distal esophagus.
This is a 61-year-old man who does not like to go to doctors, so he has no past medical history, excellent performance status, worsening dysphagia, 70-pound weight loss in the last 6 to 9 months. Endoscopy showed a circumferential GE junction lesion involving the distal esophagus, GE junction, and again going into the stomach. The biopsy showed high-grade neuroendocrine neoplasm, most consistent with neuroendocrine carcinoma, large cell type. Proliferative index was 50%. There was no adenocarcinoma there. So what is the most optimal treatment for this patient? This patient has an early stage disease confined to the esophagus and the upper portion of the stomach. So my plan is to start him on chemoradiation with cisplatin and etoposide, like a small cell type of regimen, and then follow with 2 more cycles of chemotherapy. But I would really like to know if anybody else would treat him differently. And then any role for, if he has a good response, any role for surgery after.
All right, the second one is tough. The first one, Florian, I'm going to let you start off with. So tell us a little bit about germline testing in gastric, and then how you would approach someone with known Lynch and presenting with advanced disease.
Yeah, thank you. Family history is important, and Lynch syndrome is not the only condition that should guide us to germline testing, CDH1 mutation. as Yelena already mentioned, is also a very important hereditary syndrome. 2 to 3% of our gastric cancer patients have a hereditary background, so we should test for that. Actually, I was a bit surprised here with the Lynch syndrome because we have a lot of MSI high patients with gastric cancer, but majority does not have a hereditary background. Majority is caused by methylation, older patients, etc., but it exists. And concerning management, of course, there is a role for immune checkpoint inhibition in these patients. The question is to be combined with chemo, yes or not? I think that's more or less an open question. According to labels that we have, we usually combine with chemotherapy. Maybe we drop chemotherapy early on if there is a response and keep these patients on immune checkpoint inhibitors alone. An open question is the role of PD-L1 in this situation, because some of the MSI high cancers are negative for PD-L1, but probably nevertheless they respond. But this is an open question where we need more data probably.
Sam, can I just add something?
Sure.
I think it's critical to confirm that this is an MSI tumor. I've had Lynch patients who came in with, previous history of colon cancer, and it was assumed that they were MSI, and then we actually tested the gastric cancer, and it was MSS. So, I think sometimes it's just sporadic and bad luck, so it's critical to do that.
You mean testing in the tumor, not
The tumor
only
for somatic alteration, because not all gastric cancers in those cases, even in Lynch cases, like you said, most MSI gastric cancer is non-Lynch. So I've had a couple of people in my practice actually that was unfortunately Lynch, but MSS gastric.
Yeah.
I mean, usually we have this information because we go for the DNA mismatch repair enzymes by immunohistochemistry.
Right.
So we really have that information today.
Yeah, there was a recent paper on MSI heterogeneity, so certainly something to keep in mind. Zev, you got a minute to take us through this high-grade neuroendocrine, locally advanced case. I know all of us see these every once in a while. So how do you
These are not a lot of fun, but I agree with the management. I think that platinum etoposide is the way to go here. I think that certainly, as it relates to large cell versus small cell, there's probably maybe not as likelihood it's going to have as quick a response, but I certainly agree with this management. And then if indeed the patient's non-metastatic, I would operate on that patient and I would try to cure them after a good response. One of the things we know about platinum etoposide is very high response rate. The question is it going to be durable? And so you could give it a test of time to see, and at the right time make that decision and do an operation. But I wouldn't not operate on this patient if they have a sustained, non-metastatic scenario.
And are you thinking like platinum etoposide followed by with radiation or chemo alone?
Yeah, I mean, I think that's very reasonable, and it has, radiosensitizing agents in other cancers. You extrapolate from that data, you follow them with chemotherapy, and I kind of agree with Dr. Gupta here on this approach. And then, a few months later, if they're still in that situation, I would consider an operation.
Yeah. And then what about the brain? Do you look at the brain? I'm staying on you with the brain.
I don't know about the brain. I'm not looking in the brain
like
necessarily here. Yeah, small cells, right.
In this case, I would definitely look.
All right, let's
if you
get
look
to
too hard, you'll find.
Let's get to the next case.
The next case is from Dr. Matthew Strickland, a 63-year-old man with metastatic gastric adenocarcinoma who's currently receiving second-line therapy with ramucirumab paclitaxel.
This is a 63-year-old gentleman with advanced gastric adenocarcinoma, proficient mismatch repair, HER2 negative, and PD-L1 CPS score of 0, who demonstrates clinical and radiographic progression of disease after 4 cycles of first-line FOLFOX. My question is, what second-line therapy would you recommend at this juncture?
So what's the follow-up to the patient?
This patient certainly progressed, and I started him on second-line conventional paclitaxel and ramucirumab. I couldn't quite get him onto a trial that I'm excited about at MGH, but my plan in the third line would be for this trial, and I've initiated screening for it.
What is the trial?
The trial is a bispecific antibody that targets a surface protein called Claudin 18.2. It's overexpressed in several cancer types, but certainly gastric is one of them.
I'm offended that there was no trials that Dr. Strickland was excited about it at MGH, but I'll work on it.
No, he said he couldn't get it on the trial. He was excited.
All right, Florian, this leads into your topic very nicely. But so first-line patient progresses on FOLFOX with no prior PD-1, and how do you think through standard second line?
Yeah, I think Dr. Strickland did what is recommended in guidelines. The combination of taxane, paclitaxel, and ramucirumab is standard. It's a good treatment. It leads to up to 30% response, so that's absolutely correct.
I will say that, I think all of us really should encourage more clinical trial designs in this setting. And I think we're leaving second line behind here, which I personally think is a big mistake and an opportunity for lots of drug development, because we've done a great job, I think, in some respects, moving all these drugs to front line, and we'll hear about them from Florian in a minute. But I think we're neglecting a very, very large group of patients, which is HER2 negative metastatic gastric cancer. What do you do when they progress through chemo? And if we have to start looking at that patient a little more carefully.
And if it existed, let's say, Florian, if this patient had the option of Taxol, RAM, and PD-1 in this setting, knowing the CPS 0 on a trial, would you consider that a reasonable strategy?
I would be interested to see data on that, yeah.
All right, well, this leads us perfectly into your talk. So I'm going to let you take the reins for walking us through later line.
Thank you so much. It's selection and sequencing of therapy. And I think it's a good fact that we are able to sequence treatment in metastatic gastric cancer today, that we have a first line, second line, third line. And we should be aware of that because still many patients do not receive second, third line for a variety of reasons. And this is from the ESMO guidelines, and they are quite similar to the recently published ESCO guidelines. Stratify for the biomarkers in first line, PD-L1, according to our opinion, HER2, certainly. And then in second line, ramucirumab paclitaxel is a standard. We need to integrate trastuzumab deruxtecan now, as it is available in Europe since December. MSI high needs to be considered by latest in second line, and we have some third line options like TES 102 or irinotecan, if not given before. And now there is something new. We have 2 positive phase 3 studies investigating the Claudin 18.2 antibody zolbetuximab. One was presented today by Kai Shitara, the Spotlight study. Many of you have seen that probably. And a press release shows that there is a confirmatory trial, also phase 3, called GLOW, which is also positive. Claudin 18.2 has already been mentioned. It's a tight junction protein, which is expressed in 35%, 38% of gastric and gastroesophageal junction cancers. In normal tissue, it's only expressed in gastric mucosa and in no other normal tissues. And a group from Germany developed an antibody directed against Claudin 18.2 zolbetuximab, and I'm really happy that I could work with these people from the beginning. It's, by the way, the same people who developed the BioNTech vaccine for COVID. It's the same group of researchers. And this antibody zolbetuximab binds to Claudin 18.2 and causes ADCC, CDC, so immune phenomena, which may ultimately inhibit the cells of growing. So it's not a targeted treatment that interrupts signaling pathways. It's a targeted drug that induces an immune reaction close to the Claudin 18.2 positive tumor cells. We did some studies that showed that zolbetuximab in vivo in the patient really causes immune effects. I'm not going into details here and just show you or make a short repetition of the phase 3 study that was shown today. Spotlight included patients with previously not treated first-line metastatic gastric, gastroesophageal junction cancers, HER2 negative, Claudin 18.2 positive, with a specific test. 75% of the tumor cells needed to be positive for Claudin 18.2. Some stratification factors according to region, number of organs involved, prior gastrectomy, yes or not. The chemotherapy backbone was FOLFOX. This was combined with zolbetuximab given every 3 weeks or with placebo. Primary endpoint, progression-free survival, secondary endpoints, overall survival, overall response rate, and some others. This is the patient cohort. It's approximately 70% non-Asian patients. That's maybe important to know. 30% underwent prior gastrectomy. More patients with stomach cancer than with EG junction cancer. You can see the patient characteristics on the slide. This is the primary endpoint that was met. Median progression-free survival in the control arm was relatively high, being 8.67 months. In the experimental arm, 10.61 months. Hazard ratio 0.751, which is statistically highly positive. This is the survival data. Subgroup analysis shows some consistency across the different subgroups, maybe with some more effectiveness in the Asian population, some more effectiveness in the stomach compared to the EG junction, but overall, no subgroup that was negative for zolbetuximab. Interesting to see that the overall response rate did not differ between the two arms, but there was a higher proportion of patients who had a long duration of response. The median response duration was similar, but the amount of patients who had a durable response was higher with zolbetuximab, which probably explains the curves that you have seen before. Some attention needs to be put to side effects, especially gastrointestinal side effects. Nausea and vomiting is a typical side effect of zolbetuximab. It's probably an on-target effect. As I explained to you, this protein is expressed in the normal stomach mucosa. But the good news about that is that this side effect mostly occurs during the first and the second application, and then there is some adaptation to that. So it's considered to be manageable by those who have a lot of experience. It was mentioned already by Dr. Strickland that Claudin 18.2 is also a target for many experimental treatments. I'm just showing here the CAR T cells investigated against Claudin 18.2 positive stomach cancers with some amazing effects, but there are also BiTEs, antibody-drug conjugates, bispecific antibodies. A lot of things are going on now in Claudin 18.2 positive cancers. FGFR2b will become another interesting target. There is a study that is called the FIGHT study, and some of the people here on stage know it better than me. Bemarituzumab is a monoclonal antibody that binds against FGFR2b. Patients for this randomized phase 2 trial have mostly been selected by immunohistochemical proof of overexpression of FGFR2b. But interestingly, adding positive ctDNA for FGFR2b added some of the selection criteria, and the patient population with the highest effect were those with immunohistochemistry overexpression and ctDNA positivity. That's maybe also an interesting direction we can go in the future. I was also asked to talk shortly about what's going on in the second line with ramucirumab. Paclitaxel ramucirumab is a standard. We are currently investigating the combination of FOLFIRI and ramucirumab in second line in Germany. It seems to be quite interesting for those patients who have previously received taxanes, which we are giving in the perioperative situation. There, the combination of FOLFIRI and ramucirumab may be interesting. And then, of course, combinations of anti-angiogenesis and immunotherapy will become very interesting. Just some insights. Ramucirumab given post-immuno-oncology seems to work well. This is data from Japan. Also, and that's also interesting maybe to know, ramucirumab in HER2-positive patients who previously received trastuzumab seems to work better than in HER2-negative. It's a subgroup analysis from Rainbow, partly confirmed by a nationwide registry study from Korea. So stuff for discussion. Should we go to ramucirumab paclitaxel in HER2-positive in the second line or trastuzumab deruxtecan? I think that's an interesting discussion. Here are the points you can read later. The slides are available. Thank you very much for your kind attention.
I feel like you covered a lot of stuff, and we could probably have a whole session just on later line management, but certainly encouraging some new targets and some stuff coming down the line. So we're going to move into the final module, which will be concluded with Zev's talk, but we can open up with some cases.
Dr. Gurveen Kaur is providing care to a 57-year-old man with a history of dysphagia who was found to have a lower esophageal mass that proved to be an adenocarcinoma stages T3 and 3.
He underwent concurrent chemoradiation with weekly regimen of carboplatin and paclitaxel for 5 weeks, and he did do very well with the treatment. His follow-up imaging was consistent with response to treatment. He did successfully undergo the esophagogastrectomy, and his final pathology was still showing he had residual disease along with lymph node involvement as well. He was initiated on adjuvant nivolumab.
So, any questions you'd like to hear the faculty discuss about this case?
Are experts still considering using FLOT in the preoperative setting, how they would decide whether patients should get chemoradiation or just preoperative chemo? Does that CPS number have any role in patients who are getting treatment in the adjuvant setting?
Dr. Liudmila Schafer is about to start treatment on a 75-year-old man with HER2-negative metastatic GE junction adenocarcinoma.
Interesting, his first symptom he described as need to sit straight in order for food to pass through. This is on a PET scan. We see brightened left supraclavicle lymph node. And then on the next slide, cross-sectional area at the liver is gastrohepatic. And on the next is this gastroesophageal adenocarcinoma. And also he had on a different slice the pulmonary nodules. In Keynote 590, they use 5-FU and cisplatin with pembrolizumab in the first line. And regimen cisplatin and 5-FU is very toxic. So it's really difficult for patients to tolerate. So for this patient, would faculty approach differently?
All right, I think the first case really highlights a very ongoing topic that comes up a lot, which is about incorporating PD-1 in the adjuvant setting. So, Zev, just briefly, does the PD-L1 status affect your thinking of using adjuvant Nivo in someone who would have fit Checkmate 577? And then the second part, which is maybe even more interesting, is someone gets non-standard, like FLOT in the neoadjuvant, and has residual disease. Is it adjuvant FLOT still the answer, or are you thinking about IO there?
Okay, so the first question, do I consider PD-L1 status in adjuvant Nivo? I think short answer is no. I think the study showed efficacy in both, and I'll show some of the data later on, but efficacy in both PD-L1 and positive and negative patients. May not be as effective, is a fair point, but certainly I wouldn't withhold it in the context of what may be a curative scenario. As it relates to the second question of would that change? I mean, I think, if you are treating this as gastric cancer and you're calling it gastric cancer, then we don't yet have data for gastric cancer in the context of the adjuvant setting. We're all waiting for that, and I think hopefully the next big meeting will have some of that. But right now, I would look at that and say, gosh, it's gastric, not esophageal, and we're going to wait for the adjuvant data.
Yeah, I think very appropriately. I mean, I think we've seen Attraction 5 press release, which is a little different situation with upfront resection and adjuvant chemo Nivo. Florian, let's talk about people who are either getting definitive chemo rads with no intention to get to surgery, or someone like this who maybe declines surgery for other patient preferences. Are you thinking consolidation PD-1 after, let's say, they got neoadjuvant chemoradiation, or we need to wait for data?
I would wait for data, and I must say, in my experience, we see very few of these patients. For us, for the adenocarcinoma patients, surgery is really standard. We try to convince these patients that they should undergo surgery. We see it differently for patients with squamous cell cancer that more often go into durable, complete remission. But we would try to convince this patient to undergo surgery, and we would not consider to give an immune checkpoint inhibitor if they refuse surgery. We would just wait and see.
Yeah, I think certainly a question that a few trials that are ongoing are asking about consolidation, chemoimmunotherapy or immunotherapy alone. Yelena, let's talk a little bit about practical management of someone who gets neoadjuvant chemorads, gets surgery, would have fit 577. Tell us about, are you guys scanning people before you start Nevo like they did in the trial? Are you waiting for long time recovery? The trial allowed up to 16 weeks before you started adjuvant. How do you sort of actually manage these people that fit that?
Yeah, it's a great question. I don't typically scan before I start, particularly because, as you said, there's a lot of post-surgical changes and so forth. And I wait until the patient's weight loss stabilizes and they nutritionally are in fair shape. I tend to agree with Zav. I don't restrict by PD-L1, but I also don't do usually a full year. It's a bit much. These patients have been through a lot, and most of them, if they're fit, we try to get them through a year, but it's just hard to continue treatment after all of that.
Yeah, I mean, it was kind of interesting in 577, at least in the subgroups, the people that waited longer to start Nevo, like after 10 weeks, seemed to do better. All right, Zev, you have a lot of experience with frontline chemo regimens. Sometimes we're mandated to give a certain combo because the trial says that's what we have to do, but cis-5FU, pembrolizumab, you mentioned cisplatin exchange for oxaliplatin. In this esophageal patient, true esophageal patient, are you still looking for 5FU oxali, or are you thinking?
I mean, if look, reimbursement aside and all the dosing issues aside, right? Because these drugs are dosed differently depending on 2 weeks, 3 weeks, 6 weeks. I think a lot of this data, particularly in the Keynote 590 study, you have an open blanket almost of label of what you could use there. So there's no mention of the cisplatin or the 5-fluoropyrimidine required. So I would be comfortable with that context.
And what about, we'll go down the line, same thing, Florian?
Yeah, in Europe we can use pembrolizumab also with an oxaliplatin backbone, so we would go for that and drop the platinum as soon as possible if it's not well tolerated.
And Yelena, I'll spin it a little bit for you. If it was a squamous cancer of the esophagus, same approach?
Well, both 648 and 649 cover either. So I just decide how often I want to give them IO and then pick the backbone. I think every 3 weeks is nice if you can do it. So you could, but I would probably use oxali. And if they're swallowing, they don't want to get infusional 5FU anyway. But in most squames or adenos, if they're frail and they can't swallow, FOLFOX Nevo is better tolerated.
Yeah, I think practically for us too, a lot of it based on convenience and
right.
Some patients coming from farther away, et cetera. All right, let's go on to the next case. We're seeing Dr. Brenner again.
The final case is from Dr. Brenner, who has a very unusual patient, a 60-year-old woman with a known BRCA2 germline mutation who has a history of Hodgkin's lymphoma, breast and nanoplastic thyroid cancer, who now has a localized squamous cell esophageal cancer.
Interesting case. So a lady who's actually got a germline BRCA2 mutation who's had 4 cancers, including Hodgkin's lymphoma in the early 90s. She also had anaplastic thyroid cancer. She also had a very early stage breast cancer, and then was diagnosed in early February of 2022 with the locally advanced squamous cell cancer of the thoracic esophagus. Due to her prior radiation therapy, she was not deemed to be a candidate for radiation therapy or surgery. And because of her BRCA mutation, I elected to treat her with cisplatin 5FU, which she had some difficulty tolerating. And elected to add pembrolizumab mainly because we were probably never going to go down a road of surgery or radiation therapy. So it was almost treating her as if she had a locally advanced unresectable tumor. So my question for the investigators are, when do they use dual checkpoint inhibitor therapy in squamous cell cancer of the esophagus rather than chemotherapy? What is the role of a PARP inhibitor in patients who have BRCA mutations and underlying esophageal cancer?
Ooh, I'm going to start with the second one for Zev because I just read your clinical cancer research PARP inhibitor paper not that long ago, your own trial. So.
Okay, so first of all, there's a lot to unpack here. But I think, it goes to show you a little bit of what we don't know about germline testing and the meaning of it. I think that, if you look at this patient with germline BRCA2, none of these cancers would theoretically be listed as BRCA-associated. So there's a lot, but yet there's a germline BRCA mutation. So, no ovarian, no breast cancer, none of the ones, pancreas, none of the ones we traditionally associate with these. That being said, something very wrong in this poor woman's germline. So I do agree with theoretically managing this as has been done with platinum therapy. I think regardless of almost the cancer, provided that drug has activity in BRCA mutations, I think that's a good way to go with a platinum-based therapy. So I agree with Dr. Brenner here.
Yeah, no, I think a super interesting case. Florian, minus the germline BRCA, how do you think through the 648? You have both tools available. You have Ipi-Nivo and you have chemo-Nivo. How do you think through patient populations when you're choosing between the two?
Yeah, we are always thinking about the two options. I mean, there is a lot of discussion. There is this early detriment of the group that was treated with ipilimumab and nivolumab. So probably we need to be careful about the patient characteristics, those who need a quick response with a high tumor burden, maybe with liver metastasis, might be a group that is not so good to put them on nivolumab and ipilimumab. On the other hand, we saw today the long-term follow-ups. Those who achieve a response with nivolumab and ipilimumab achieved that for a long time, so it's certainly an option. We do a careful patient selection based on preference, on lower tumor burden, on less aggressive disease, not liver metastasis. That's the group where we recommend Nivo-Ipi mostly.
I'm going to ask a question to all of you. So we saw this recent meta-analysis from Harry Yoon and Dr. Rajani looking at perhaps the best predictors of PD-1 benefit, and TPS scoring seemed to be the preferred predictor in esophageal squamous. So does your institution test for TPS? Do you do CPS for everyone? Do you distinguish between adenos and squames? I'll start with you, Florian.
Yeah, it's very simple. We get all the information from our institute. They stain for PD-L1 and they report CPS, TPS, and IC. So that's a routine in our institution. And they say it's not so much work for them to report the different scores. It's feasible. And for squamous, I think both should be reported because you have all the options. If CPS is more than 10, you have the Pembro option. If TPS is more than 1%, you have the Nivo chemo or Nivo-Ipi option. So you need the whole spectrum.
Yeah, I think we need to do a little catching up to Germany. We don't quite have that ourselves. What about you, Yelena? Do you get TPS and CPS, or everyone gets CPS?
Mostly it's CPS, but certainly we can get TPS. But I would play the devil's advocate that you wouldn't make the Nivo-Ipi decision based on TPS. You would make it on clinical symptoms. And theoretically, there's patients exist. I've yet to find one that I would feel comfortable doing Nivo-Ipi because even for TPS high patients, there's always a crossover on the curve for the first 6 to 9 months. So some people, you crash and burn and you lose them without chemotherapy. So.
Yeah, I think we're in the same boat. What about you, Zev? Are you a TPS person, or do you guys get?
Yeah, we don't get TPS either routinely. We can ask for it and 50-50 if they'll say yes or no, but CPS is pretty much where we, in most patients, get.
All right, I'm trying to set you up for your talk, so you're up. You're going to bring us home.
I'll bring us home here with esophageal cancer and a little focus perhaps on squamous cell a little bit more, which is different. So I'll start with the study that we just alluded to, the Checkmate 577, and Ronan Kelly led. And here this was practice-changing study, randomizing patients with either adeno or squamous, and it was predominantly squamous, after chemoradiation to either Nivo or placebo. And it was a year of Nivo, and the primary endpoint was disease-free survival. And we all know the results of the study. The curve separated pretty much after 6 months and stayed separated throughout and led to a very clear indication, doubling of disease-free survival, and led to the approval of Nivo in that context. And keep in mind, as we've alluded, these are patients who had some residual pathology left after esophagectomy. So patients with complete path CRs, which is not an infrequent finding here, were excluded from this analysis. If you look at all the subgroups, and this is what we've been alluding to here, there's a better data set with respect to PD-L1 high, CPS 5 here you see, and TPS high. In all analyses of CPS, these patients did better. So I think, to the question was asked earlier, is it important to get the information? Yes, it provides you prognostic information. Would it necessarily mean you wouldn't use the drug? In my opinion, no. I would still use the drug in this context, as we alluded to earlier. And here's a number of other stratification factors, almost all of whom favored Nivo over placebo in this context. There's a subtly different endpoint that's been reported in this study recently, disease metastasis-free survival, which is alluding to a slightly different group of categorization, and here too, there's benefit. Now, we're waiting, and we haven't seen yet overall survival. And overall survival of this study is not a slam dunk necessarily. We're going to see it because of the number of patients who got immunotherapy after early progression. So, I think we're all waiting to see that data. Our expectation, hopefully, there will be an overall survival advantage, regardless of the drugs utilized, and I think that's the de facto standard. But we're waiting for that OS data. And here, safety summary, quick synopsis of what we already know. There's a trade-off. As Yelena alluded to, a year of therapy isn't easy for a lot of patients with Nivo, but ultimately this is a curative potential, so we try to push through. Now, if we look and summarize early-stage gastroesophageal, as we've talked about, I think Nivo is clearly the standard of care in these patients, regardless of histology, PD-L1 status, and final pathological stage. We're waiting for OS data. We're waiting. We don't know what to do with these patients with a complete path response. It's a hard question to answer, and is not currently, to my knowledge, the subject of any large randomized study designs. We're waiting on a lot more data from definitive chemoradiation, not a small group of patients in the United States, certainly, who are candidates for esophagectomy. We don't know what to do with these people as the role of immunotherapy. There's been a bunch of studies that are ongoing we're waiting for the data to tease out. And perhaps the biggest data set we're looking for in gastric cancers, do we extrapolate what we've seen in esophageal cancer to gastric cancer? We don't know. Keynote 585 is probably the biggest one, or one of the bigger ones to read out. There's another big one, Matterhorn. There's an attraction study, of course. So all this is coming in the next year and could certainly change our management of early-stage gastric cancer. At this point, I don't give early-stage gastric cancer patients a checkpoint inhibitor. Again, Keynote 590, we won't get into this in too much detail, but again, randomized study comparing chemo plus pembro versus chemotherapy plus placebo, mostly squamous cell, but some adenocarcinoma in here as well. Primary endpoint was overall survival. Here in table format, you could see study met its endpoint. The study was well balanced, but you could see it had in adenocarcinoma only 26, 27%, 73% squamous cell. So again, globally, squamous cell is a more common cancer. In our country, in the United States, adenocarcinoma is far more common. The patients did the best on this study were the esophageal squamous cell carcinoma with CPS greater than 10. So their cutoff, pembrolizumab studies, a lot of cutoffs is CPS 10, not 5. It's again, different antibody, 22C3 compared to 28.8, but here you can see a hazard ratio of 0.59 in that group of patients with pembro plus chemotherapy compared to placebo plus chemo. So there were different ways of looking at this data, but by and large, if you kind of try to spin down what's the best group of patients, it's the PD-L1 esophageal squamous cancer greater than 10. Now, Checkmate 648 was updated today. Florian just alluded to it. This is a squamous cell only study randomizing patients to one of 3 arms, chemo-nivo, chemo, or nivo-ipi. And the 2 experimental arms weren't compared directly to each other statistically. So again, alluding to what my colleagues are saying, it comes down to a clinical decision making. We're not going to answer the question based on a study. We're going to leave the judgment up to the investigator. And I agree with most of what everybody said, which is based it on disease burden and think characteristics of that nature. Here you could see in the group of patients who got nivo plus chemo, the study met its endpoint. Today's presentation, which was a 3-year follow-up, but we don't have the Kaplan-Meier curve on that. The curves did start to come together towards the end there. So, and that, in my opinion, is distinct from nivo-ipi. Nivo-ipi, here's the separation of the curves, and after that initial crossover, which, as Florian alluded to, reflects this group of patients who may be progressing rapidly, those curves stay pretty far apart. And on today's presentation, those curves stayed quite well far apart, quite a bit better, actually, than nivo chemo arm. So there is a tail of the curve here, which we're not used to seeing in this disease, and they're used to seeing in lung cancer. But here in this nivo-ipi arm, maybe some patients here with very long-term, I dare say, cured with metastatic squamous cell carcinoma. So I do look for this regimen in the patients who have low volume disease and who don't need a chemo bump. Now, I'll skip this, but long story short, the hazard ratio here, there's other endpoints that people have looked at more recently, like PFS2, response rate. All these duration of responses all favor nivo chemo and nivo-ipi over chemotherapy alone. We're not going to do another study comparing those two arms, so ultimately it is a clinical decision making. Now, targeting esophageal squamous cell carcinoma, as I alluded to, is very different than adenocarcinoma because squamous cell carcinoma biologically is not the same as adenocarcinoma. It's a lot more like, if you look at TCGA data and some of these other genomic databases, it's a lot more like head and neck cancer. It's often virally mediated, totally different etiology, risk factors, and so forth. So this may lend itself, this cancer, in my opinion, amongst all of the upper GI cancers, may lend itself to additional immunotherapy manipulations. And PD-1, CTLA-4 may be just one angle, and hopefully in the future we'll see more. So just quickly, we saw today tisli plus chemotherapy. We didn't see this one, but we saw it last meeting, tisli plus chemotherapy, same data with a combination of PD-1 inhibitor showing a survival advantage with tisli plus chemo over placebo chemo. The curves look very, very similar to what we might expect with the Checkmate 648 study. So, another PD-L1 inhibitor. But down the road, I think what we're hoping to see, and I'll skip through this real fast, is that we can target different aspects of T cells in combination with PD-1 inhibitors. So I don't think the story is just going to end with PD-1, CTLA-4 inhibitors. I think there's a few that look promising, and I'll just highlight, I think TIGIT is a negative regulator on T cells that people feel may have activity. Tiragolumab is one of the TIGIT antibodies pretty far along in development, and it has a focus to some extent on squamous cell carcinoma of the esophagus as relative to other GI cancers. And we've already seen there's a slew of these studies ongoing, of which we're waiting for the results, including some on the bottom with definitive chemoradiation. Finally, I think we're all, looking for LAG-3. We've seen some disappointing LAG-3 data in metastatic gastric cancer as it relates to dual targeting of PD-1 LAG-3. But perhaps here in squamous cell carcinoma, as alluded to earlier, we have an opportunity to do a second immune checkpoint blockade beyond what we've seen already. And maybe in the future, and I think one of the speakers said this nicely, we may be able to put chemotherapy further and further beyond for selected patients with squamous cell carcinoma of the esophagus. And I will stop there. Thank you.
Awesome. Thanks, Ev. All right. Well, we have a minute or two, but just want to make sure I thank everybody. I think we're all still friends after this. At least I'm still willing to buy you guys all a beer. Thanks for spending your evening with us. I know that there's a lot of things you could be doing. Hopefully this was informational. It seems like there's a ton of stuff to discuss next year when we can further dissect more Claudin data. We can talk about some new targets. We can talk about more updates. Maybe we'll see some perioperative immunotherapy results. So really, this is going to be an area for a lot of ongoing discussions. Just a reminder that there is another program tomorrow talking about hepatobiliary cancers, another area where we're thinking about sort of subdividing, slicing up the pie by biomarkers. And I think will be some interesting talks and some great faculty. So once again, thanks for attending. Don't forget to fill out the final surveys about us and what we can do better and how we can make this better for all of you. So thank you again.